second year resident student, I'm sorry, not medical student. Second year resident going into radiology, but his residency is at Baptist. He just wasn't able to do it this year first. Okay, so these are all the different lines and tubes that we're going to go over. A lot of the ones that are going to be most important for you is obviously going to be the endotracheal tube, tracheostomy, ET tube being the one that you're most often going to encounter in the ER. But then some of these others, such as peripheral line, PICC line, if you're going to be in any hospital medicine, you're probably not only going to learn how to insert those a lot of the time, but you will be obviously reading imaging. Anytime you put a line into somebody's body other than a Foley catheter, you should get radiology once everything is stable to confirm the correct placement of that line. That is your responsibility. You're not only confirming the placement, but you're also looking for any possible complications that were encountered during the placement of that line, such as dropping a lung or perforating whatever tube that tube was to be going down through, but then it perforated through, whether it be the esophagus, the trachea, the intestines. Okay. And then obviously, just like Dr. Lovelace said yesterday, any radiology imaging is always going to be read by a radiologist. That's their specialty. That's what they do all day long. So even though you are looking at it, it will be overread by a radiologist. But if you see anything suspicious, then you need to be calling the radiologist and say, I need you to look at this now. Because he's got a docket of readings that are kind of lined up for him. And unless it's stat that you allocated on your order, most of the time if you're in the emergency room, that's automatically going to be a stat order. But if you're on the floor or replacing something in the ICU, that may not always be allocated as stat unless you indicate that. So make sure you don't forget that important component on your orders. And then, inevitably, if they don't call you fast enough as well, you can call them. It's also good, too, to build that rapport with the radiologist. Also, you could give them any information as far as, well, I had a little bit of difficulty placing this line. I'm a little concerned about telling them what happened. And so then they would be more diligent about slowing down because they do their readings really, really fast. Not saying that they just willy-nilly look at them. They're very skilled and can pick out things. But sometimes when you give that additional information, it helps them to really, really focus. All right, so peripheral IVs. Obviously, your peripheral IV, just a head block in that is not going to be X-ray. But we're more so talking about a PICC, which is a peripherally inserted central cath. But that is a peripheral IV. So that's why I put both of that together. A peripheral IV being a PICC needs to be X-rayed, not just a peripheral IV head block. Don't X-ray a head block, that's not me. All right. Internal jugular, that's what IJ stands for. Subclavian or femoral, so those are also called central lines, but it's named after where you started that central line. So whether you started it by accessing the internal jugular or the subclavian or the femoral, then that's what they call it, an IJ central line or subclavian central line, a femoral central line. We used to do these a lot in codes, and I was taught to do them without ultrasound because that's how they did it back in the old days. We will be doing them ultrasound guided, and we're going to teach you a little bit of techniques even starting tomorrow with ultrasound. But you'll learn that a lot in Capstone. You certainly will have no inclination of feeling like you're adequate at doing that by the time you're done with Capstone, but at least you've been introduced and you're going to be able to play with it a little bit. With using the transducer, which is the name of the thing that you're holding that the ultrasound waves are going through, and then whatever needle or line that you're trying to place. We're making some molds using chicken breasts and placing lines inside there. We're kind of trying to be really creative, which we've not done before. So hopefully it all works out so that you can kind of try to use that and see if you can coordinate your hand-eye by watching on. I'm excited about where it is. Okay, umbilical lines, obviously we're talking about newborns or pediatric, so neonatals, which are less than a week of age. And then your large bore temporary catheters, so your tunneled catheters, which are usually on either side of the chest, going into the subclavian leg from there. Dialysis catheters are also called that because it's mainly used for dialysis patients. And then just ports. So it's a circular thing that goes in. You're not going to be placing ports, but you may be needing to assess that port for accessibility. If that patient comes into the ER and they've got a port, you automatically know that this patient has a chronic illness that they're needing treatment chronically for through that port. And your first question, after you kind of get the gist of what's going on, would be, when's the last time your port was accessed, and may we utilize the port? Because whatever they're using it for, their endocrinologist or their specialist is going to say, don't let anybody else use this port, or they may use it if they need it. And that's important for you to ask. Don't just assume you can use it. And then it would be up to you to test the viability of that. So flushing it to make sure it works before you just tell your staff to go ahead and use it. You also in the ER may be seeing that patient just for troubleshooting that port. Because they come in and they say, oh, my home health nurse said that I need to come in and have this tested because it's not working. She can't access it, so therefore I can't get my IV antibiotics or my treatment. And so then you would be ordering that test, sending them to the radiology to have those lines tested. Now, that was rule whenever I had to troubleshoot them. In the city, when I did interventional radiology, it was the interventional radiologists and the interventional radiology team. So that was one of the things that I did as a PA in interventional radiology, was to do the fluoroscopy, which means the table, you have your own room, and you've got them laid on the table, and you push the foot pedal for intermittent live imaging. So it's like watching the video on the screen, but you're working it with your foot by when you're doing that live filming. Just knowing that while that live filming is going, they're getting radiated, so you minimize that as much as possible. But you're flushing it with a radio opaque, something that you can see, so that you can see the latency of that line. All right. Swan Gants, that's usually used in cardiology for like art lines and that. And then peripheral, Swan Gants is more centralized. Peripheral art lines way down usually in the radial area. ECMO, obviously, this is something that you're going to be in a higher level care center. That's the extracorporeal cardiac big O machine. I don't even know what those letters stand for because I've never had to deal with that. But I've got a few pictures to show you. If you ever saw images of that, you'd be able to identify, oh, that's what that is. And then you've got all your enteric, which means your GI lines here. So you've got oral gastric, nasogastric, peripheral epigastric lines. And then your OJ and NJ being your oral and naso-jejuno-ostomy lines. And your ostomy catheterizations, whether they go through the wall of the abdomen, usually. We had a patient in Good Shepherd where we were doing the urostomy catheters. You don't have to use, you could use ultrasound to guide you, but she was well established and had had that for such a long time that her tract was very well established, so we didn't have to monitor that or use radiation to place that or replace it. Manometry probes, those are more so like the pH probes that are put down the esophagus during certain GI procedures. I've never seen that or encountered that, other than they may have used one when I was asleep and I had my EGD for my reflux. I don't know, we didn't ask. but that would be an example, as well as the esophageal temperature probe, which is just about that. Sorry, I skipped that one. Tracheal, again, your ET tube is going to be the most often ones that you do in the ER. And then your tracheostomy, obviously, once you've placed that, you're going to order that image to confirm that placement. So drainage, any of your drainage tubes, and it all goes with where it's being put in. A chest tube, you guys have heard about, obviously you're going to be using that for a pneumothorax, any of those type of traumas that are within the chest pulmonary area. A UE is a temporary, smaller catheter that is put in superiorly, kind of where the needle decompression procedure goes. So I used these in interventional radiology if I had a patient that I did a lung biopsy on and then I caused an iatrogenic pneumo because we didn't seal off the thing fast enough and they sucked a little bit of air in and they had a little bit of free air. If I didn't immediately try to fix that, since it was fresh and new and I caused it, that could potentially get bigger and then collapse their lung. And so, since my procedures, were outpatient, I wasn't going to send that patient home without treating them. So obviously it has to go through different protocols and have to be a certain percentage, but anything greater than 10%, we would put a UE line in if I wasn't able to immediately suck that air out once I saw it before I took them away from my CT room. And it's just a little pigtail, small catheter that goes in the same area that your needle decompression is for a pneumothorax. Your pigtail drain, so you'll see pictures of that. That could be anywhere from inserted into an abdominal abscess, into the kidney for renal access. People that have urostomies that drain their kidneys because they have no other function. Some of your end-stage renal disease patients have those. I helped my my chief radiologist in interventional radiology place both of those as well. So there's a lot of cool stuff you get to do in interventional radiology. And then there's large drains, chest tube being one of those, but then there's obviously others that would be, so like a JP drain for an abdominal procedure, such as a cholecystectomy or a choledoangitis, where it's inflamed, but the only way for them to get that fluid out of there is to have a drain inserted. You know those bulbs, I'll show you pictures of it here in a minute, that are pushed and then they essentially suction out and pull the fluid postoperatively out of that. Any big wound, surgical-wise, sometimes we'll just have drains because you don't want it to be building up within the wound. That helps that wound to heal by keeping that fluid off of it. So those types of drains, I'll show you pictures of as well. Peritoneal dialysis, so anytime somebody is having that fluid drawn off, or even just a chronic patient that has a liver cirrhosis that builds up so much fluid consistently that they need a chronic line in there. You're just going to leave a peritoneal dialysis line in there, and they wear a bag just like they would for a urine bag. And then ventricular shunts, so people that have hydrocephaly. Those shunts, obviously, you're not going to be putting them in unless you're in neurosurgery. But you have to be able to identify them. If any of these patients come in with these lines, you've got to be able to identify what that is and note that in your notes so that you can look and make sure there's not any complications or anything wrong that you can see. All right, a lot of anatomy with this. So we're going to start again with our vascular access, and we're going back into our peripheral lines. So the most common areas, and I started thick lines in interventional radiology as well. You use ultrasound to help place those, and so you're going to get the peripheral vascular vein access either through the brachial, basilic, or cephalic. So those are the three most common that you're going to access. And then you essentially push that line in to track all the way up into the subclavian vein and then it also goes down into the brachiocephalic vein into the superior vena cava, and then down into essentially the SBC atrial junctions, where you want the end of that line to stop. Risks and benefits of peripheral lines. Just like anything else, I always, with doing any type of procedure, would explain to my patients there's always going to be, anytime I cut the skin, a risk of infection, complications of blood clots developing, complications of bleeding. Okay. We try to protect that as much as possible, obviously by doing sterile technique, and you'll explain that to the patient. And then you obviously will do imaging afterwards to make sure that you're not at any higher risk because of any complications that may have been encountered. So you're going to image it to make sure that the placement was good, as well as no signs of complications, like internal bleeding because you went through the vein, which is called extravasation. And you would explain all of those things to the patient. Some people like to throw statistics in there, make them sound smarter. I prefer not to, because inevitably if I try, I mess them up. So I always say there's always a small risk. It's not a large risk, but there is a risk and you need to be aware of it. All right, so this is a picture of the heart, obviously showing you the SBC. And right where it goes into the right atrium, so that's essentially the area of where the PICC line is going to stop. Can you see that? I wish they made this little thing red or light up or something. You can't really see it very much. So. This is the right side of the patient, which is the most common side that we would use, because to me, you had more complications of other things coming from the left, but sometimes patients have contraindications of using that right side. So anybody that's had a mastectomy or lymphatic drainage or abnormalities of that right side, you obviously are going to have a higher risk of complications due to scar tissue or anything else that may have developed. So, again, those are questions that you're going to ask. Have you had any surgical procedures in the area that I'm going to be performing the procedure? You do your physical exam just like you would on anybody else, so you listen to their lungs, make sure they've got good lung sounds on either side, because if you encounter and cause a perforation of the lung, then you've got the before and the after. You look at the skin, because if there's any sign of infection where you're going to be putting that line, you never want to stick a needle through a dermatologic infected area, because then you're just inoculating them with whatever they were infected with into their bloodstream. Bad form. Do not do that. Don't just assume that it's red, oh, it's normal. Just don't go there. Choose a different site. Don't take that risk. So this line here is just showing it coming from the left subclavian and coming down into that same area, being the superior vena cava. I usually stopped my line right in here, and so between the third and fourth rib is how I used to say where I wanted. Third, fourth, and fifth rib space is always a good placement on that side where the superior vena cava is. So when you do your x-ray, you're going to be able to see your line, and you're going to be able to see your ribs. You're not really going to be able to see the actual vena cava very well. You may be able to see it a little bit, but not very well on an x-ray. And you certainly won't know exactly where the superior vena cava and the atria come together, but that is the anatomical location of your target endpoint for a PICC line or a central cap at all, okay? This is just the lateral view, the same thing. It just looks different because you're looking at it from a different angle. All right. Anatomy, just a bigger picture of that. And then again, more specifics of the heart, the pulmonary arteries, transposed with an X-ray bridge. Okay? So again, showing you that 1, 2, 3, 4, 5. So right in here is your optimal location. That's really a lot lower there. I'm sorry, it's the 4th, 5th rib spacing right in there, which is actually, they're counting 1, 2, 3, 4, 5. 6, 7, down. Maybe I counted 3 ribs between the, it's been a long time, I just remember again, like number 3. Your test question will say, if it is on your test, at the junction of your superior vena cava and the atrium. This is what the central line or PICC line looks like. Used to always be called a triple lumen, but then they started to make single and double lumens, and so then it confused everybody. We now are calling it, or maybe that was just layman's terms, but PICC line, to where it's the peripherally inserted central catheter. Just like I said, when we say we're going to start central lines, that could be a triple lumen. It could be a dialysis catheter that has 2 lumens or a single lumen. A port almost always just has a single lumen to it. But again, they may revise that equipment. We just know that it is a peripherally inserted cath is going to be a lot longer because it's got to travel long enough to do that. When you learn that procedure, there's certain measurements that you will be given where you're going to measure from on the body with a tape measure. And then every line that you ever put in a body is going to have markings such as these black marks. Some of them will have numbers, some of them will just be black marks. So then when you measure, you're going to use the tape measure and measure where it's going to go into the body, essentially, which is this thing. This is what you sew. These holes right here are literally what you put the needle through into the skin to sew it to them to stabilize that. So it's just not taped down like an IV. You'll numb it up with lidocaine, just like if you were doing stitches, and you sew it down. Because one, these are going to stay in longer, and you want to protect it. This is going straight into the superior vena cava, into the heart, into the bloodstream, so not just into the peripheral vascular access in a limb, but straight to the heart. So obviously you want to be very, very particular with your sterile technique. Do not want an infection on that. These are all the items that you would use. Obviously, you can have your syringe with xylocaine, saline flush, or heparin flush. With a central line, you would flush it with heparin rather than just regular saline. This is what it looks like pulled straight out of the package. It has a hardware plastic that's got it coiled up that it is housed in the package, and that helps it to keep its shape and protect it so that it doesn't deteriorate or get cut. But this is what it looks like when you pull it out of this. This is curved like that for a reason. One, you can only use one hand to hold this. Two, you've got to keep it sterile. You can't touch anything before it's being pushed into the body with your one finger, okay? Because you're holding it and pushing it in. So this is the only logical way for that to have worked. So that helps you to place it in a sterile fashion. Do not take it out of the package and just take it completely out of that. Obviously, you're going to watch one before you do one, and then you're going to teach one. So pay particular attention to those motions that they do. This is the catheter that you initially would use to kind of make a bigger hole. Transducer is what those are usually called. And then this is the wire that's fed through it. So this goes in, and then this wire is fed all the way close to where you want it to be. And then this line goes over the wire. Then once you have confirmation of everything looking good, you will pull the wire out, flush it, confirm it with X-ray, and then sew it down. Okay, so obviously here's your suture material, needle driver, everything just like you would be doing suturing, laceration repair. 4x4s obviously for any drainage of blood, and then you're in saline before they hook up whatever IV antibiotic to it. Anytime you are starting one of these, you obviously want confirmation. You can flush it, but do not ever hook up an IV or a big bag of fluids until you have confirmation that your placement is correct. Your first sign that it has poor placement is that when you go to flush it, and you're going to be the one flushing it initially, it's not going to flush very easy. You're going to have to use a lot of force. And when you get a lot of resistance, don't overly try to force it, because that means it's probably not placed right, and you need imaging before you try to be a little bit more aggressive. If you didn't confirm and then you just started IV fluids, especially if they were pressure infused, and you had punctured and went into a lung instead of into the vascular access, then you're just pouring a lot of fluid into those lungs. So see how that's very, very bad form. Confirm the placement before you use any line other than a Foley catheter again. Your Foley catheter, once you pull back urine and see that it's clear without blood, you're pretty much confirming that that's into the system. That's the only line that I would say you don't need imaging before you use it. And you're not putting things into it usually. All right. Oh, back to that. You also have mine just went blank. What is that called? What is the tape, the plastic tape that they put over a headlock?
Dr. Latazzi told us that.
Is it Tegaderm? Yes, I know it started with, no.
Isn't that what
That's like
Dr. Latazzi was saying to increase the flow of steroids? You remember what it was?
I was thinking it started with T. That might be right. I'll find out.
That's it, yeah.
Is it Tegaderm? Google it. Somebody Google it. Now it's bothering me. I'm pretty sure it's Tegaderm. Because my brain was picking out the T. Anyways, Oxide is another word for it. I obviously used that one because I forgot the other name. But that is just covering that up and sealing that off. Even though you've sewn it on there to make it stable, you're covering it and sealing it so that you don't have direct line again for somebody to be messing with it with their fingers and introducing bacteria or coughing on it, and, spilling liquid on it. So you're covering that up. When you place those oxides, a good rule of thumb, and you'll be taught this, but you will always put your initials on it, the date and the time. That tells anybody that's looking at that who to go to if they have any questions about it, when it was done, not only the time but the date, because there's protocols on how long, depending on whether it's an IV, central line, port, dialysis catheter, everything has different dates of how long those can stay in there. Now, obviously, if you've got any site at all that gets red and starts looking like infected, you disregard whatever those dates are, and you're going to obviously pull it, change it, and treat them for infection. Okay? So, don't forget. And a lot of them will have a space for you to write on. And I usually did that, and it is good form to write on it before you put it on the patient. Because then it's really, really hard to write on them. Unless you have like a derm pen or a Sharpie. But then again, it's just better form, and you're not writing on the patient. All right, so this is the peripheral IV line, local access. This obviously is very short, only goes about this distance. Doesn't go all the way down, but you could have a PICC line that, and your PICC lines usually are here, here, or even here. Okay? Not all the way down here. Your ART lines will go into the radial artery sometimes. The Swan-Ganz lines may go there as well. Here's a picture of what the PICC line, and I know that this is a red line, so it's not going to be red, but it'll be a dark white that shows you the placement of that. 2, 3, 4, 5, 6, 7, 8. Okay, I should have looked that up because it seems to be more like the 8th rib. 1, 2, 3, between the 3rd and 4th rib after the clavicle. That must have been my technique. I don't know. It's been a long time and I should have studied before I give this lecture. Sorry about that. So that must have been my technique, the 3rd to 4th space after the clavicle instead of, because sometimes it's hard to see those upper 2 or 3 ribs on an X-ray. And so I felt uncomfortable with trying to go 7 to 8 because I'm like, is this the 2nd or the 1st or the 3rd rib here? It's hard to see how many's up there. So, again, that's obviously not a question on the test of wood space, but technically they will teach you how to do that as far as your placement. All right. Again, when you order that chest X-ray, it's a single view. Most of the time these patients are in the ICU or hospitalized and they'll just take them up to the room because you don't want to be moving them around again, getting them more exposed to infection when you've just put in a central line, dragging them through the halls. Anybody else that could be walking by coughing on them. So they will bring the portable chest X-ray, do one view, and then let you know confirmation there. This is same technique, exact same start point, but it's called a midline. Just go out and because that line just goes midway. It's the easiest way to remember the name of that. I never placed these. This is not a central line because it's not going into the central part for inferior vena cava access. So the main thing is on a midline, the tip does not pass the axillary vein or essentially the clavicle on an X-ray. Okay, so again, these are vascular central lines, vascular access, venous access from the internal jugulars. So you've got your right and your left internal jugulars. These, you will always use ultrasound to guide you to place those. I never did IJ's central lines way up into the neck until I did interventional radiology. We were taught to do blind, I guess they were subclavian lines when we were starting central lines, because our technique was blindly to go just above the clavicle, mid-clavicular line, and aim towards the apex of the heart. It was nerve-wracking because you're in the middle of a code, and that was protocol back then, to always start a central line on a code once you accessed airway. And so you've got airway going and chest compressions going, and then you're like getting everything ready to start your central line, and you say stop chest compressions, try to place that central line. A lot higher stressful, and they figured out that we could do it otherwise with a peripheral line and be just as effective and not have all that stress, so they quit doing it, obviously. So you guys don't ever have to do that, okay? You will have ultrasound guided, even in Blackpool America, because they have the fast ultrasound machine. I actually was going to start working there again last December when they were really needing somebody to fill in, and then right as my credentialing was all set to go, and I was like ready for them to tell me my schedule, they were like, we found somebody that's going to work full time, so thanks, but we don't need you. man, I was going to be able to teach you guys. But obviously I went and spent time, not only interviewing, but going through the facility that they have revamped because it is updated and it's definitely not the same facility that I worked in. And they are more modern and they have more modern equipment than I had to. So all the horror stories that you've heard me say with ER and the lack of stuff has definitely improved. So you will have the fast ultrasound that you're getting ready to be introduced to tomorrow. So this here, don't let this picture scare you, but this is a picture of somebody doing a femoral art line here. I'm sorry, a femoral venous line, central line. We used to start those during codes. I honestly can say I always did here. I never chose to go femorally. I have drawn femoral art blood gases during a code. And that may be something that you are asked to do still, but I don't know how often in the city that would be asked to be done. As well as through the past 3 years of lectures, I've heard them say they're not really doing ABGs as much during codes because the venous blood gases are just as good. So again, that may be something that's gone to the wayside. But if you were to have ever placed a line there, then you would order an abdominal KUB X-ray for confirmation. That's the only thing that I would say you need to know on that. And this is what it would look like to show you the placement there. And that obviously is going to go into the inferior vena cava, not the superior vena cava. And it doesn't have to go all the way up into the, you don't have to push it and track it all the way up to the heart. It stops. That's long enough. It's going to go where it needs to. All right? This picture's in line. I may not be able to do some of the stuff I wanted to because I can't move that. So the next one, they're talking about a tunnel Hickman or a Robiac line. Hickman line, those were the ones that we used for dialysis that are more long-term, and those were done in interventional radiology. Those are also central lines started, and that's what this is here. Started in the chest wall rather than in the extremity. You start that, you can see here, this is where I would use the ultrasound to access it through the internal jugular. And that's where initially everything would start, and I would feed the wire, and you would use fluoroscopy in the cath lab. So I got to work in the cath lab, so that was fun. But after seeing my supervising physician and me assisting him and doing probably about 10 of those, he said, okay, the next one's yours, and I didn't realize that was coming until it happened. And that scared the shit out of me, because when you're feeding that line, you literally have to have it into the atrium of the heart. You don't start at the superior vena cava atrial junction. You go into the atria. Because it is used for a longer period of time and used for dialysis, the port is larger, and they're using, obviously, a lot of different medications other than just IVs or chemo. So that's why we were in the cath lab too, because you had to watch your wire go into the atria, and you had to make sure that you kept the tip of that wire that kind of flutters like this because the heart's pumping, and make sure that you're not getting close to the SA node, because if you touch the SA node, you can cause them to go into VTAC or VFib. So therefore, it makes you nervous. That's why you're doing it under fluoroscopy and in the cath lab. So once you got the wire and everything fished down through here, then you literally cut here and then put the port and tunneled it. So this is a tunnel access, and this prevents infection more so than if you just had the peripheral line. That's why it can stay in longer. So the most important reason you would use a tunnel catheterization primarily is that tunneling under the superficial skin before you go deeper is actually decreasing the possibility of an infection. Oh, I added that yesterday. I wanted to make sure you guys knew that. So here's normal chest x-ray. See how you cannot see any vasculature at all. I mean, if you were to say, if I would say, tell me where the inferior vena cava, you could kind of guess. It was right in here. Oh, just click the next one. And the superior vena cava, I'm sorry, subclavian, right subclavian being here, and then going on into your anatomy over here, venous cephalic. And then obviously the next picture shows you. So, again, the arrows are pointing to what you want to look at. Obviously, you're wanting to look and follow this to be the same pattern every time. Sometimes you get a little bit of resistance because there's a couple of things that you have to go through that kind of tunnel through other structures here, and it can coil up on you here. So even though you measured it and you fed it to your endpoint of that black mark that was your target of what stopped feeding, that doesn't mean that it was straight and went all the way down. It could have hit one of those junctions and coiled back up in here. So even though the depth was correct and you thought you were in the right place, it's still not going to work and not be a confirmed good placement. You also want to check your heart border and making sure that you're checking, obviously, for good lung markings throughout that lung, so that you're double checking that you didn't cause a pneumothorax or a hemothorax. And then also checking for any free air under the diaphragm on this area. Just not that you're ever going to go into through the diaphragm, into the peritoneal area, but I guess it's been done before, or they wouldn't say that that's something that you need to watch and make sure of. I guess if you didn't measure it right and you kept feeding and feeding and feeding and then punctured through, that could be a possibility. So, you don't want to feed the line all the way into the atrium again, because you don't want to throw and hit that SA node and throw that patient into a cardiac arrhythmia. Sometimes you will see one that gets pretty darn close to the diaphragm, and the radiologist will call and say, you need to pull back. That would be the only thing that you would need to do to fix it. Obviously, when you've got your patient in, doing this procedure, so you'll do them on the floor in ICU as far as the PICC line out here peripherally, not the dialysis catheter central in the chest. The one peripherally you'll do on the floor. But again, they'll always be hooked up to telemetry, and somebody will be watching that same time that you're doing that procedure, always, to let you know if they're having any change of their arrhythmia. So I'm just going to show you some pictures of poorly placed. So instead of it going down into following the right subclavian down into the superior vena cava, it followed the track and went up into the internal jugular. So again, they were right on their end marking here on no longer feeding it in, or they got to where it was giving them resistance. So once you meet resistance, you don't automatically pull it completely out, because the more you go in and out and in and out, you could be causing infection. You just check placement, and so now I see this placement, and I know I'm going to pull back probably 5 to 6 centimeters to where it pulls the line back up over here, and then I'm going to try and advance it again and see if it will take the correct track. Okay, you're not going to pull completely out and start all over again. So this is showing, obviously, they went in from the left, which again is completely fine, and you may have to do that if there's contraindication on the right, but there's obviously a lot more other junctions for it to be causing a problem with tracking correctly. But this one went all the way down, way past into the atrium and down past where it's supposed to be. So you would just pull that again. So it went into the inferior vena cava instead of tracking into the atrium itself. This one, instead of going down where it's supposed to, just tracked across and went into the right subclavian vein. So see how important it is for you to do imaging and check your placement? That line and that wire doesn't have a driver on it to know where you're wanting it to go. It just follows whatever vein it's in, lumen. This one, it kind of just started to coil up again. Could have actually perforated through. Sometimes you'll meet resistance and it doesn't take a whole lot of you pushing through resistance for it to perforate. So you're going to be really, really dainty and nervous in the beginning when you start feeling resistance not to push through. But then once you do several of them, you'll know the difference between resistance that's okay for you to push through and resistance that's not. That one just went into the azygous vein there. This one tracked over on the other side. Okay. I tried to study last night how in the world it ended up in the aorta. I don't have an explanation for that, other than perforating. That left subclavian does not hook up to the aorta, unless they had an anomaly. Anyways. So this one was coming instead of from the internal jugular or the subclavian over. Again, they just stopped in the right subclavian. Oh, no, it went into their lung. Yeah, I missed that. So the importance when you're seeing line placement again, not only, go back over to here, see the difference between in between the rib spaces, you're seeing the interstitial markings, the lung markings. Can you guys appreciate the difference between that shadowing and then this shadowing? Much darker. Do you guys see the lung edge? Can you appreciate that? So here's the actual lung that's collapsed. Okay. It's easy when somebody points it out, right? So that was the beauty of what I was going to be able to do, was to show you, because digital X-rays, it blows my mind, because I still practiced an era where you had plain films, and literally I was doing this in the dark, holding it up to a black light, or not a black light, a bright light, and looking at films that I held in my hand. You guys have the technology now to change the density. So remember he was saying yesterday where you would be able to tell whether or not they used too much power and they burned them out because it was too white, or they didn't use enough energy or density and it was too dark, and it changes the appearance. Well, you literally will be able to click a button on your mouse and move that mouse one way or the other and change that density variation, which helps tremendously. And then you will also have a button at the top. You'll have different, they're not called tiles, they're called different buttons that will give you different tools, so you can invert the image. So everything that's white is black and everything that's black is white. And it helps you to see it. Just like when Dr. Lovelace said yesterday on an EKG, for you to be able to see a posterior, you flip it, turn it backwards, and look and see the posterior MIST elevation, right? We used to do that with X-rays because we had them in our hands, and we'd flip them and turn them upside down to catch rib fractures. Well, digitally, you'll be able to flip that image and rotated it just like you can a picture on your phone or whatever program that you have. So you guys have so many manipulative tools that you can use. And he started some of those pictures that he was flashing up yesterday on radiology, and they started changing colors, and I'm like, what in the world? I have not been trained. My eyes don't see colors. As color to me is always blood flow. It's what I've ever used color for. Obviously, there's newer programs now that I have not had experience with that you can change colors that help you to see certain things. I can't educate you on that because I have no experience in it. I don't know what it's telling you, but I do know that you'll be able to just push a button and swipe your mouse to change the density and be able to see things. And it will be night and day. You would be able to do that and make it even darker and darker, and you'll be able to really see that's that lung drop, and there's absolutely no lung markings here, which proves that there's a pneumo, and proves that there's a puncture there, that that's not just in the right subclavian. Okay? Because see how the right subclavian literally arches and then goes into the cephalic vein? You know, you could easily think that that patient may have a little anomaly and that that's where that starts with that branching. But they actually punctured through here, the wall of the superior vena cava, and went into the lung tissue itself. You can see the tracheal air, bronchial air markings here and the carotid of the trachea. That's a good good marking to always learn as well. So again, here's a good picture of the anatomy, and knowing all these different branches will help you to know when you see an angle a different way, where that end of that line ended up in the wrong area. Still doesn't show you connection to an aorta, so I'm thinking it's perforated somewhere. All right, babies. So we all know that the vascularity of the umbilicus is different than anywhere else in the body. So everybody's body has, with every major artery, has two veins in one artery. It's the opposite in the umbilical part. So you have one vein and two arteries. And then it starts getting tricky as far as how those track up into the baby. Okay. This is representing the opening of the umbilicus, which would be the umbilical cord still that's attached to the baby. Okay, that's why it's not on the baby itself here. That's representing the cord. That's why it's going down like this before it goes into the baby there. Okay. So you will, if you're ever in deliveries or in the ER sometimes, you will have to start umbilical lines. And I've done it a couple of times because I used to do peds attending on deliveries within my first year of being out of school. One of the most memorable ones was a baby that was born with a diaphragmatic hernia and was crumping and not breathing right. So we had him tube, see the ET tube? This is not that patient, but this baby has been intubated as well. So that's what an ET tube looks like. See the line that lights up? And proper position of that is right, ending at the carina of the tracheal tree. But the diaphragmatic hernia was on the right, and so the liver and abdominal contents was up in here, and the heart was pushed way over here. Just really changes the anatomy somewhat. But that was one baby that I was trying to do confirmation of the central or the umbilical line, and I was like, holy crap, there's our problem. Did you do what's called a babygram? That's what this is called. One view babygram. And essentially it's all the chest, abdomen, pretty much everything, all in one view. Okay? So you're starting the, oh, there it is, babygram, it's abdomen, KUV, chest x-ray, all of it together. Counting vertebral bodies, so you're looking at the spinous processes, so knowing where you need to terminate, okay? Know the anatomy of the vertebrae, so there's 7 cervical, 12 thoracic, 5 lumbar, 5 sacral. Obviously, I don't ever count sacral. I start at the top of the sacrum and count my lumbar thoracic circle. There's transitional anatomy. Sometimes there's going to be off by a number or two, so don't let that freak you out. And just know that if anybody ever says it, don't argue with them because that's true. But your landmarkings that you're wanting to know on a baby, certainly try and figure out where the first rib is, know where the 12th rib is, and then know where your S1, where your sacrum starts. Okay. Part of this stuff transpose over, but his sacrum, that baby's sacrum starts here. It is a little boy. Little Throckmorton. Have you guys ever heard of Throckmorton thing? So Throckmorton is only on a male, and it's usually, and you'll see this in trauma all the time, 99% of the time, the penis points to the side of pain. And it's called Throckmorton syndrome. It's just a sugar of the soup question, I don't know. Dr. McNeil taught that to me. Taught it to our class, not just me. But if you're ever asked that, or if you ever see that on the boards, it's a question that Dr. McNeil wrote. He has written questions for years, so it's amazing, and you will feel comforted. You will probably be able to identify them because most of the time you've encountered it in your didactic year, and it's almost identical to the same exact question. So you'll have that whole bad day of taking your boards, but those few moments of going, oh, I know that question immediately because it was Dr. McNeil, and you can identify it. Or you could say, I would bet money that was Dr. McNeil. Anyway, it made me feel good. The 4 times that I've taken it. And it's not the same questions every time, but you're able to pick those up. All right. Sorry, I just had to shake that. So we're doing umbilical venous catheters. So you are using the venous access on the baby. And again, there's 2 arteries, 1 vein. The vein is bigger than the arteries, as well as the most central opening in the umbilical cord. Okay. There's so many different things that can go as far as feeding a line umbilical-wise, but the main thing is that it's going to go down and enter into the iliacs before it goes into the inferior vena cava. Okay. What they call the celiac trunk, sorry. Again, it's going down before it's going up. That's the most important thing on a umbilical line, and don't get freaked out that wherever you put it and wherever it starts in the body, it doesn't just start tracking immediately up. If it does, then it's not going where it's supposed to be. Something's wrong, okay? You can do, I'm sorry, you could do both venous and arterial lines. I did venous because the vein is bigger, and it was just easier access. You can obviously do both, but just know your anatomy when you are of whichever vessel you are using. So your target when you're doing venous is the inferior vena cava. When you're doing arterial lines, it's going to be stopping at the T6 through T9 vertebral body. Again, their vertebral bodies are a lot more squatty and small, and you know, you've got to start from the sacrum. You can't really start from the top because you've got all this. I can't tell where C1 and 2 is. So it's just easier, even on full spine, lumbar spine, I start from the bottom and go up. Now, if you're in neurosurgery, the neurosurgeon, he can start anywhere on an MRI and know the anatomy to every detail and tell you what level he's at. I'm not that good, even after doing that for 3 years. All right, so here's your anatomy. Again, a lot of complications, a lot of different variants. Don't stress out over the weekend on memorizing all of this. I'm not going to do that either. All right? If you are going into neonatal care at any point in time or emergency medicine, please know this because you're going to have to know it. So, just by stressing, this shows you all the different variants of the lines once it's being fed. Okay. This one here, again, this shows you where it enters the belly. Obviously, this is representing the placenta, and there's the cord itself. So you're starting where the cord was cut. The umbilical arteries go way down before they go up, and then the umbilical vein, again, goes down a little bit, but not as much as the artery, and then goes through the hepatic portal area. Now, when you get to this area here, see this junction that goes straight across the hepatic portal vein instead of going into the inferior vena cava? That is probably the most important thing that I would want you to know. Because if you start an umbilical line and it's going north, once you start going north, it should continue to go north and end in a northward fashion. It should never start going north and then turn at a 90-degree angle in either direction. If it does, it's not a good placement. Most of the time, if it's heading towards the liver and it takes a 90-degree angle, it's ended up in the hepatic portal vein and not a good placement. So your umbilical lines do not go all the way to the heart, okay? They stop at the inferior vena cava, like I stated earlier, or the celiac. I don't even see the name of where that was terminated, other than on the previous one as far as the 6 to 9 grade. So, obviously, if you're doing arterial and it goes downward and stays downward, not good placement. That's an easy, bad placement. That's fine. Here's a picture of it going towards the liver and then doing the 90-degree angle. Okay. And this is what it looks like on the baby. So you've got all of this coiled wire going from the umbilical cord itself, going down first and then up. So they've done both. Oh, you know, I bet they did a venous line first, and then it went 90 degrees, so then they started arterial and had good placement there. So they'll pull this one. So obviously this one went bad into the hepatic portal. So you've got a right hepatic vein, left hepatic vein. Sorry to confuse you. So this one went into the left hepatic vein. This one went into the right hepatic vein. So it doesn't matter which way it does that 90-degree angle. It does a 90-degree angle of the hepatic portal vein. This is one, started arterial, and they were feeding it, and it just continued to kind of, when it started to go up, but then it coiled back down and went down. So again, reason for placement, even though you have the link from where you think it should have ended up here, it didn't. It just started to coil upon itself like a rolled up garden hose. So making sure you've got placement where you're not going to get good perfusion of those fluids, extremely important. Could be a matter of life or death. I've got another picture of this, but I see this one. I don't know if you'll be able to appreciate that or not. Look at this line here. And then bam, it stops there and then starts back up there. These lines can fracture. That's what that would be called. So again, you're meeting resistance and you're trying to force it, just like a straw. I think Dr. Lovelace actually talked about this a little bit yesterday. It fractured within that vein just by the force of you trying to force it. So obviously that's not going to be working very well either. And then you've got a foreign body floating around. That's not good. Not figured out. This is a lot of air in the valve, and then you've got your gastric bubble. This is not in very good shape at all. I don't know if that's the lung and this is a pneumo, or if that's the heart shadow from this being pushing everything, but if we don't have tracheal deviation, not real sure what's going on. Baby's definitely still alive. All right. Here's another one. It went down and never came back up, so that's bad placement. This one went up. Looks like it's probably going to end up in good placement. Don't let this be your final view. I think they just zoomed in to focus on this here. I think this is just a zoom in this. So you actually could see where it terminated up in here. But if you just got this view, then you say, do it again, I need the whole view. Do not ever be satisfied with not being able to see everything you need to see. This one obviously went way past the point of where it needed to go. We're done with the baby. Here's more as far as your ports and IVs. This is your arterial line. So this is a renal artery art line. Sometimes you will see these for patients that have to have routine blood gases. When I was a phlebotomist, sometimes patients would have blood gases ordered on them every 6 hours or every 8 hours. If they were on a ventilator and they were having to change those settings quite frequently, it all went off of those blood gases. And so they put in a peripheral art line, which is what that's called, so that I wasn't having to stick them with a needle in new access site every time, for one reason. But two, arterial blood gases are painful. Your arteries have a thicker wall. They also have a lot of nerve endings, and they're very sensitive, so it's painful. So you don't want to be sticking them every 6 hours in the artery, causing them that amount of pain every time. And you also don't want to be sticking them every 6 hours and possibly inoculating them with an infection right into the arterial lining. So multiple reasons of why they would put that in when you're having to access it multiple times throughout the day. A lot of the times they were in the CCU, which is the cardiac care unit, because they had just had a heart cath or some other cardiac procedure, and so they had to have that access during surgery to put their thrombolytic in, and then they just left it again so that you could continue to monitor for blood gases as you need, and then once they're satisfied, the patient's stabilized, they remove it. You'll never be removing those unless you are in cardiology, more than likely. All right, so I've already talked about why we would use ports, again, for long-term medications. That even goes through with home health. patients will be sent home with ports or PICC lines. If they're getting IV medications, home health-wise, every daily basis, or every 8 hours, or however it is, they'll have those. If it is not flushing, what you would be doing is checking for what we call a fibrin sheath, because things scar down. Anytime we put anything foreign in the body, it walls it off and tries to scar down. This is a picture of a port here, and the line going in here. So that was one of those tunneled Hickman catheters, central lines, okay, for dialysis. Again, I guess the arrow's pointing here. I should use my arrow. I can't even see that very well. So 1, 2, 3, and 4. I'm still within that same rule that I had between the 3rd and 4th rib space below the clavicle. Again, do whatever protocol that they ask you. This patient's got a very healthy thin heart. This is what it would look like on an arteriogram. Just to show you that. This patient's got tons of lines. So sometimes you're going to have pictures brought to you or sent to you, especially if you're going to do internal medicine and your internal medicine rotation. You go to look at the chest X-ray. You need to know what all these lines are, be able to name them. Okay? So you've got your ET tube. This is probably just an EKG monitor, those little lines that they have on their external body to monitor them the whole time they're. Here's the other one. 1, 2, and then the other one's probably off the page here. So you got to be able to identify. Oh, they probably were actually doing an EKG. You've got tons of these wires just looped up around. It doesn't always mean that these lines are inside the body. Make sure you're looking on the outside of the body. Sometimes patients are laying on top of things as well. So anytime you see any abnormality that's not expected, you need to be able to identify it and name it. So it's another reason why I'm kind of giving you an introduction on these. Swan-Ganz catheters. So here's a picture of, it kind of looks like a triple lumen, only there's a 4th lumen here. It's a bigger line, and then it's going down not only into the atria and into the right ventricle, but then you're going over and going into, and these are things that we use to monitor for poor pulmonal. What the mean arterial pressure is within the pulmonary artery, or your map. That's how you get that measurement. But again, unless you're going into pulmonology or cardiology, you will not be placing these, but you need to know how to identify it. And again, I did not do internal medicine, nor was I ever practicing in a hospital within the city, so I guess that's what this is. So I don't even know how to identify it. It's going down and then going across and over into the right pulmonary artery. So that's what these arrows are indicating. You see that? Again, this is just another picture of the large bore dialysis catheter. Same area, it's just tunneled in. We initially put the nick here and then tunneled it through and placed it. This is a dialysis machine. I've never ran one. I've only seen it in a dialysis center only because I went with a family member. Actually, it's no longer a family member. It was my ex's family member. All right. So temporary ports versus tunnel. Again, the reason you would do tunnel is to prevent infection if it's going to be on for a longer period of time. These are the ones that are only accessible by a dialysis, and the patient will know to tell you, you cannot use this. Okay? Sometimes patients just have ports that are not tunnel catheters or dialysis catheters because they have horrible, horrible veins. And if they're hospitalized, and you know, when you're hospitalized, you monitor things almost on a daily basis as far as blood work. And so they'll put a port in so that the phlebotomist doesn't have to be working and poking that patient 5 or 6 times before they can access blood. Or even for an IV access, you need IV fluids to go in, and so they put a port in. Not necessarily, it's not going to be a tunnel dialysis catheter. There's a difference, but they look very similar. So again, ask the patient, can I use this port, or can I use this catheter? And they'll tell you whether or not you can use it. That's what, on X-ray, what it looks like, the little thing that you sew to them. All right. This is an example of an ECMO, what the vasculature and all that. Again, I have no knowledge of this. I've never encountered it. Don't expect you to know it. Just wanted you to see that. As far as also, I didn't make this. So I think Dr. Femoral went way into too much detail and kind of blew all of my students away last year. So I'm simplifying it for you guys. All right. See all the tubes with ECMO? I'd be going, ah, no, my league, I don't know. Well, I don't even know what that is. That looks like a coiled spring. That looks like a frog leg. Looks like a syringe. I don't know what that is. This baby has a baby. No.
The tear tunnel.
Yes.
I know that this is. Well, no, it's not. That's way too low to be an easy tube. That's not what that is. All right. Keep calm and prevent CLABSI. CLABSI is obviously an acronym for your central line infections, bloodstream infections. So if anybody ever uses that term, you'll know what that is. So these are the complications. I think I've already covered most of them as far as putting central lines in. We've gone through enough pictures to scare you about malposition. So now I've proven at home that whatever tube or line you put in, you better darn well get an X-ray and confirm that it's a good placement. So, malposition, pneumothorax, we've seen that, kind of scary. Vascular dissection, hematoma, so you can cause a blood clot to form in that area, and then obviously, you know, that's bad if it's in an arterial area, because then you can cause a stroke, because that could feed off into anywhere else, or PE, which would even be worse, because then that's impending doom. All right. Air, catheter, or wire embolism. So catheter, that one that fractured, is like a foreign body. That's what it would be called if that was a catheter embolism. They don't just call it a foreign body embolism, they name it. So an air embolism, everybody is scared freaking to death of air emboli. You'll see, and you'll see it for years, nurses flicking the syringe to get every itty bitty teeny teeny tiny air bubble out of something before they inject it, especially into an IV. That used to make me nervous. I used to say, yeah, that was legit. Until I did interventional radiology, and I used to do assist in their transesophageal echocardiograms. Because they actually do a test where he shoots a almost full 5 cc to 10 cc of air into the heart. Yeah, and at first I was like, you're going to do what? See your mouth open. And he's like, see, I told you it's not going to kill them. I want to do this because this is the only way that I can confirm this. And I'm like, okay. So he's like, all the stories and all the horror things that you ever heard about air emboli, it takes a lot. So don't freak out about an itty bitty small air bubble. But don't argue, let them do what they've been taught. Don't cause a big argument, because there's several people that die hard rule live by that. But just know not to freak out if you ever see a little itty bitty teeny tiny air bubble in an IV line, it's okay. Okay? That was the gist of my story on that one. But air emboli do exist. The most common cause of ones that are dangerous are your divers. So your deep sea divers, people that are going scuba diving, the rapid descent or ascending, okay? That's when it has a lot of air building up, because it's the whole capacity of your lung volume shooting through the heart, and then it's almost like a sump pump for your pool, not being able to prime. People that have had pools know what that, does anybody know those are? Okay, yes, okay. So, yeah, it can't prime and it can't circulate. That's kind of what an air emboli does to your circulation if it's big enough. So, but, sorry if you don't have a pool or have ever been around one. That's what the concept is. Okay, and then I've already talked about the arrhythmia, and then, most importantly, even though it's on bottom, infection. Okay, so, know the complications of vascular access. Again, those are the things, obviously, you're not going to say all of those risks. As long as you're saying you have risks and you're going through the most common ones, risk of infection, risk of bleeding that covers your hematoma, covers your blood clots. You know, it doesn't mean that in court you say you didn't, well, they didn't tell me that could happen. I told you overall complications with me inserting anything into your body as a foreign body. That way that covers your foreign body wire, embolism, all that kind of stuff. You don't say, I could puncture your heart. If you're doing a tunnel catheter of which you're ending in within the heart and having that higher risk of causing an arrhythmia, yes, you need to say, that can cause your heart rhythm to go out of its normal rhythm. But that is why we have you in the cath lab, and that is why we have these monitors on you, and we have full training and a full team that will be there accessible to give you medications to control that and to put you back into the normal rhythm, which is what you all learned in ACLS last week, okay? All right, so even though it's scary and it happens and we know how to fix it, just like the pneumothorax that I could have easily caused and did cause 3 when I did interventional radiology, the coolest thing is learning how to fix it immediately by just sticking the needle on the catheter that I had my finger over and sucking the air back out. And magically, it was gone. And that's how you fixed it. And I didn't have to do that pigtail. The only time I had to do the UE, and it was only one time, and I actually didn't cause it, was because they pulled the whole transducer out, being done with the biopsy, before they had confirmation of any complications of the X-ray post-procedure before pulling the catheter out. Okay, so again, we do things in medicine, but we know how to fix it immediately. It's kind of cool, and that decreased my anxiety for pneumothorax from that point forward. All right, enteric. So, I obviously did not specialize in GI. I have done very few gastric lines because that's something in the ER you really don't do. If you go into GI and that specialty and you do EGDs or you do gastric lavage or gastric lines to suck the contents because you need them to have their GI tract completely empty, then you would do. I have done, because back in the day, I have done gastric lavage in the ER, as well as used charcoal, and for patients that were overdosed. So back before they changed all of that, that was the protocol. You stuck this whole garden tube down their throat while they were awake, and you preached to them the whole time. Just swallow, swallow, swallow. I know this is uncomfortable. They're crying. They got snot coming out of their nose because you lubed everything up. And they're trying to breathe and feeling like you're suffocating them because you're cramming that big of a tube down them. And you're like, I've got to do this so that we can get that out of your stomach. You guys don't have to worry about it. Okay? as soon as we got that down there, then we pushed the stuff in and suctioned it out. And we kind of did that through a bag until we no longer saw any pill particles or components from within the stomach visible, and then we pushed the charcoal down into that area to absorb anything else. Always a mess. You got black crap everywhere. If they coughed or threw up, it was all over. And that was the whole understanding of why you wore scrubs. And your white coat now became black and was no longer usable. All right. So this picture obviously is just showing you the anatomy of the GI tract down to the stomach, showing you obviously esophagus versus trachea. I did do dysphasiograms, which is what this is. This is fluoroscopy and a still shot of the fluoroscopy. So push the pedal and watch them swallow radiopaque liquid, whether it be barium or gastrographin, same kind of stuff that you would do for contrast studies. That's what this is. And then watching the pattern of where that went for their swallowing. So a dysphasiogram, we literally watched for how big the vallecula is and how narrow their esophagus got into here before it went into the normal swallowing pattern. We also watched for a beak, like spill forward, we would call that a beak sign, for patients that had trauma or strokes, anything that caused a dysphagia or inability to swallow or handle their secretions. You did a dysphasiogram before you put them on a full diet or even a full liquid diet, because you've got to make sure that they're safe and swallowing appropriately and that everything muscular and neurologically is working and functioning fine so that they wouldn't be aspirating that. So that's why dysphasiograms are done as usually people that have been in car accidents and had any type of neurological abnormalities, patients that have had strokes because of obviously they've had a speech impediment. It's not only affecting the vocal cords, but it's affecting the musculature that helps with the swallowing aspect, okay? People that have been intubated for a long period of time could have damage and scar tissue around the vocal cords, and so obviously it's also going to cause difficulty with swallowing. And so you've got to make sure that they're not having that positive beak sign showing that the liquid's going down the esophagus and nothing is spilling into and beaking into the trachea, which could cause them an aspiration pneumonia. So, that's the extent of my specialty on enteric. I'm going to show you a lot of these pictures within the gastric of where, like, the EG tube and so you could possibly be doing an OG tube, like if we did the lavage, but very rarely are you going to do that in the ER. NG tube, being nasogastric as well. Just going to show you what it looks like on imaging, because again, you may be in internal medicine seeing some of these on imaging and you'd be able to identify it. People long-term with trauma also might have like PEG tubes, gastric tubes put in. So this is showing you the anatomy of the small bowel as well as, so here's the stomach, and then you've got the ileum. There it goes, ileus and the jejunum, right? No, duodenum. Sorry. Duodenum here. In the ileus and jejunum. Pancreas obviously behind the stomach, so what they've done is they've cut out the stomach itself so that you can see everything behind it. Duodenal junction goes back posteriorly and then turning around. So the pylorus is obviously where the stomach first dumps its contents into the duodenum, and then the duodenum connects to the jejunum here. All right. Here shows you the tract of the NG tube, going up and then back down. Again, you will use lidocaine jelly, so or xylidine jelly. The jelly is obviously to lubricate it, the xylidine obviously to numb it. So sometimes they use the spray, the cetane spray, before they use the jelly. It just depends on the level of awareness or consciousness that your patient has and how much resistance and how nervous and anxious they are. Okay? And the oral gastric tube usually is a lot larger tube. Again, they need to be awake for that to ask them to swallow. That helps you to prevent, obviously, from it going into the trachea. If they're able to swallow, then you've got the action of the peristalsis to feed that tube exactly where it needs to go. If they're asleep, one, they're not able to swallow, and it's almost impossible to guarantee. Usually, if you're wanting it to go to the esophagus, it's going to go in the trachea. It's just my luck. And if you're wanting it to go in the trachea, it tries to go into the esophagus. So, just make sure, again, you have confirmation of that tube placement before you start flushing fluids in, because you don't want to be starting to lavage what you think is the stomach and then lavaging their lungs. Not good. This is the small line, would be a long-term oral gastric tube, not the large bore. Hold on. This is Tammy. Okay, I'm going to actually come up and let you in, okay? All right, you're welcome. Can I ask a volunteer to run up and open the door for me? No? Okay. Wait, what door? The top, because it's locked. Oh, one by the way. Oh, no. Yes. Oh, got it. Is that one of us? Mm-hmm. We're almost done. Let me see. So, these are just some pictures of feeding tubes and gastric tubes. Obviously, again, this is not my specialty, so I'm not going to be making you know this stuff. This is just for your own information to refer back to be able to say, yes, I've seen this, and that's what it looks like. Mostly, this lecture, I want you to know how to identify your proper placement of the ET tube, and like I said, the PICC lines and the umbilical line of where your goal endpoint is and why you would use those peripheral lines. So we're going to fast forward through a lot of these. There's a picture of the pH detector that I was telling you about. All right, so here's showing you proof of an NG tube or an OG tube that they thought was in the stomach, and then they started instilling fluid into the lungs. So extremely important to confirm your placement before you start using it. Tracheostomies, that's this picture here. Again, we learned yesterday from Dr. Lovelace the correct place to put that. So it's just below the V that you feel into that soft tissue, 1 finger width below that is where your key point of making your incision and then placement. And again, you'll learn this in capstone. You'll be doing these on the cadavers next week. So don't stress a whole lot about that. Just know the anatomy of going underneath your cricoid cartilage and through that soft tissue. Okay. Your tracheal intubation, I already mentioned again, your endpoint is going to be about 2 centimeters just above the carina, which is where the junction of the right and left main bronchial stems stem from. This picture here shows the tracheostomy tube placement there, and then it ending just below the clavicle junction there. So your complications of the ET tube, again, so we've already learned from prior lectures, but this is just to reinforce it. Your intubation tube, which is your ET tube during any code, you need to make sure that you order your X-rays for confirmation of placement 2 centimeters above the carina. But the complications can be collapsing of the lung. The mediastinal shift would be causing from a tension pneumo, again, which would end up in cardiac tamponade and death. Another complication of the intubation would be an esophageal intubation. We all know for confirmation would be to listen to both axillary areas, so your right and left lungs with the stethoscope. He didn't mention listening for the gastric sound, but that would be another area that you listen with your stethoscope. And then again, confirmation with capnography, pH paper on that square thing, and I know they showed that to you during ACLS. Again, depends on where you're going to be practicing and where you're rotating on whether they use that or if they just use that capnography wave thing. But knowing the colors of that pH paper and what that means and when to troubleshoot that. Okay. Obviously, if you have poor placement, no lung sounds on one side versus the other. Most common main bronchus that is intubated is which one?
Right.
The right. And so then how would you correct the placement of your ET tube? Just pulling back. Don't extubate them completely. Just pull back. And then listen to the lungs again and compare. And get another X-ray for confirmation. You don't want to leave that last confirmatory X-ray of being the wrong placement. Get another one to confirm that you corrected it. And make sure that way it's stamped, documented the time of correction of that. And it should go along with your patient's vitals because the hypoxia is going to correct it. Right. Tracheal perforation, again, rare, but just don't be so forceful with the ET tube. I've never used a bougie, is that how you say it? Bougie? That would be awesome. I actually got online last night, Googled the price of those things while I was at the vendor name. I'm like, oh man, if it wasn't Christmas time, I might get, hey, maybe for graduation, you guys might get bougies. They were only $8. Or maybe I could do a drawing and get 10 of them maybe. All right, so again, confirmation for placement, and then obviously you're checking all of your lane markings for any abnormalities. This patient's definitely got some chlorectasis going on there. And this lung field is going across midline, so we've got a tension pneumo started. Obviously, we're it out on this side. So, right main stem, pull back. Vocal cord trauma. So again, obviously, if you're intubating a patient and it's in a trauma or an emergency situation, you're not going to be telling them that that is a risk. But anytime somebody goes into surgery, you can guarantee that the anesthesiologist is going to go over those risks. Anybody that's intubated, there's a risk of damaging those vocal cords. So again, That's one of the main reasons why, once you visualize those vocal cords, you're not taking your eyes off of them and then you're feeding that tube in, making sure you're using the right hands and you're not having to switch those around. Again, this is less manipulation and movement with one swift, smooth motion, the less trauma to the vocal cords or the trachea that you're going to do. All right. Other drainage would be such as like in interventional radiology, where we did drainage of abscesses, or even thoracentesis, draining of the lungs. This picture on the upper right-hand side is actually indicating a chest tube. Oh, there's two of them there. See the one that's even higher superiorly? Your chest tube, obviously going in, you're always, if it's for a pneumo, you want it pointed up. If it's for a hemothorax, you're going to have that into pointing down. Because your patient's sitting up, air rises, but blood falls with gravity, okay? And that's how I remember it. These are just examples of the catheters that I mentioned earlier. So the UE is a smaller, really small, temporary, usually placed superiorly. And then this is an example of the pig that just curls up at the bottom. You could have a bigger chest tube that pigtails, usually used for pediatrics, but not for adults, unless it's a really small pneumo superiorly. But again, we learned that 10% of a pneumothorax doesn't really even have to have a chest tube. With the degree that we learned yesterday, make sure you refer to Dr. Lovelace's notes to confirm that. And then anytime you put a chest tube in, you're going to hook it to suction. So you're going to get the whole chest tube lecture tomorrow. That's why I'm not really going to go over it today in detail, because I'm not taking away that thunder. But there's more pictures in here on that for you to see. Thoracentesis again, so just draining as far as any fluid that would be building up, whether it be post-surgical or from just an effusion. Is usually ultrasound guided or CT guided. Can be done both. And depending on where the fluid is and the other anatomical structures in the area would indicate your area of access, whether it be side or posteriorly. A picture of a Jackson Pratt, or what we call a JP drain, and I probably did a poor explanation of what that was earlier. These are what are used intra-abdominally, or like a lot of patients that have cholecystectomies or complications with stone within the thoracic duct area. They have a lot of drainage, or even post-operatively, just wounds themselves that need to be drained. You'll see them, but this is the tail end of it. Will coil up, and then this little bulb thing suctions, and then when you put the lid on it, it's essentially like a suction tube that's pulling that fluid out of there. This is actually a picture of a renal catheter, ostium. So like your dialysis patients or patients that are in complete renal failure, that they literally have that catheter to drain the kidney, because there's no kidney function whatsoever. And again, that's done by interventional radiologists. There's a picture of a hip replacement. I'm not sure what that is. My first guess is that is stent. Okay, that was my gift. Now that you're here, I was kind of being shy of being completely wrong. That is a ureteral stent. So those are very painful for patients. But you'll see that this line actually goes through the urethra. They take those out just by pulling that line, is that correct?
Yeah, so you'll see it in down in the bladder, and then usually there's a wire that comes out through your urethra.
Yeah.
And unfortunately, you usually follow up in the office, and we'll just
Take it out. Take a deep breath in.
Yeah.
Here we go.
You're starting a lawnmower right
like, that helps. It's just, it's very,
No fun. No fun at all. Here's peritoneal dialysis catheters. And so those are sometimes temporarily placed. Patients that have chronic cirrhotic livers and get a chronic buildup of peritoneal fluid. They may go to interventional radiology like once a month or once every other week. It just depends on how often that they build up fluid and their ammonia level, and that builds up, which is not good. But they could have a chronic catheter put in that just continuously drains, and then they wear a bag that's draining the peritoneal fluid off of them. That buildup of fluid causes pressure up again underneath their diaphragm and onto their stomach, and so they lose their appetite, they have a hard time breathing, they get those pregnant bellies, those men that walk around look like they have pregnant bellies, and then they get the edema, so the pitting edema of the abdomen and the upper thighs and that. This picture obviously is a picture of a ventricular shunt going all the way down into from the ventricles of the brain. You won't be placing those. That would be neurosurgery, and there's a picture of that, but that would be how to identify that. That's going into the bladder, that one looks like. Because the stomach's way up here. Or is it just going into the peritoneum?
it's probably just in here.
Peritoneum? Okay. All right. So here's a picture of the water suction thing that the chest tube is hooked to, and you'll be, again, going through details of that tomorrow with the chest tube lecture. Brad will go through all of that. There's another picture of a line that's fractured on that one. So again, when you're looking at lines, make sure that the line of both sides line up all the way through. Sometimes it may look fractured because it is a kink like this, and it actually came down and goes up like this. So it's not a bad idea sometimes to not only get an AP, but also a lateral. So if you're suspicious of a fracture, it may just be kinked in there. So confirm that with the lateral as well. Makes a difference with whether it's replaced or not. All right, and there's the references. Sorry I went over.